Have you ever found a tick on yourself or maybe on your child or pet and had that immediate thought, okay, what now? Is this dangerous?
It's a really common scenario, and yeah, it
Lyme
can cause a
disease,
lot of
a
anxiety.
bacterial infection
Exactly. And it
transmitted through the
often leads
bite of
down a rabbit
infected
hole
Ixodes.
of confusing information. So today we're doing a deep dive into Lyme disease. It's actually the most common illness spread by vectors, like ticks, here in the United States. We want to cut through some of that noise.
And it's definitely a critical topic. While the official reports of the CDC list about 30,000 cases a year,
Which sounds like a lot already.
right? But the estimates for actual infections, they could be as high as 476,000 each year.
Wow, that's a massive difference.
It really is. It highlights just how widespread this illness can be
Yeah.
and maybe how often it goes undiagnosed. Lyme disease itself is a multi-system illness, meaning it can affect various parts of your body. It's caused by a bacterium, specifically a spirochete, that's a spiral-shaped bacteria called Borrelia burgdorferi.
And that's spread by those Ixodes ticks, right? What most of us just call deer ticks.
Precisely, deer ticks.
So our mission today is pretty straightforward. We want to give you a clear, comprehensive shortcut to really understanding Lyme disease. We'll cover how it spreads, the symptoms you need to watch for, how it's diagnosed and treated, and really importantly, how you can prevent it.
Yeah, we'll dig into the essential knowledge, maybe bust a few myths, and share some practical advice.
Because understanding Lyme isn't just for people living deep in the woods anymore, is it?
Not at all. With changes in our environment like warmer winters and shifts in animal populations, tick habitats are expanding. So it's becoming a wider public health concern for, well, pretty much everyone. This deep dive should give you the essential tools you need.
Okay, let's unpack this then. It all starts with these, surprisingly tiny creatures, the ticks.
Absolutely.
Yeah.
The main vectors, the carriers, are those Ixodes ticks. Now, in the Northeast and upper Midwest U.S., the specific species is usually Ixodes scapularis.
Okay.
And out on the West Coast in the Northwest, it's typically Ixodes pacificus.
Got it.
But what's really fascinating, I think, is that the bacterium itself, Borrelia burgdorferi, isn't actually new. Scientists have found it in tick specimens preserved from way back in the 1940s.
Really? The 1940s?
Yeah. So the pathogen's been around for a while. What has changed is its prevalence, how common it is. And that's likely increasing because of ecological factors, things like expanding deer populations, reforestation, bringing woods closer to suburbs.
Yeah.
It all increases our chances of encountering infected ticks.
Okay, here's something that always gets me. Many people who get Lyme disease, they don't even remember being bitten by a tick.
Right.
How is that possible? How does it just go unnoticed?
That's one of the biggest challenges, honestly. And the reason is usually down to the tick's life cycle. Ticks go through stages: egg, larva, nymph, and then adult.
Right.
But it's the nymph stage that's responsible for, believe it or not, about 90% of human Lyme disease transmissions.
90%. Why the nymphs?
Two main reasons. First, they are incredibly small. Think about the size of a poppy seed.
Wow, tiny.
Exactly. Very easy to miss on your skin. Second, their peak feeding season, when they're most active, is typically late spring and summer, precisely when we're all spending more time outdoors.
Okay, that makes sense. The perfect storm, really.
It is. And remember, the tick itself isn't born with the bacteria. It has to pick it up first by feeding on an infected animal, like a mouse or sometimes a deer, and then it can transmit it to a human during a later feeding.
So let's say you do find a tick attached. Do you need to panic immediately? Or is there a window of time before infection likely happens?
That's a great question. No need for immediate panic, but prompt removal is definitely key. This is where time is of the essence really applies. Based on experimental studies, it seems like tick nymphs generally need to feed for about 38 to 48 hours to transmit Borrelia burgdorferi.
Okay, 36 to 48 hours.
And adult ticks might need a bit longer, maybe 48 to 72 hours.
Why the delay?
It's because the act of feeding, taking in that blood meal, actually triggers the bacteria inside the tick to multiply and migrate from the tick's gut to its salivary glands. Only then can it be injected into the host. So if you find and properly remove the tick before that time window closes, you significantly lower your risk of getting infected.
All right, that's crucial information. So finding it quickly is key. Now, let's talk about what happens if someone does get infected. You mentioned it's a multi-system illness. It sounds like it progresses. It's not just one thing.
Exactly. Lyme disease typically unfolds in distinct stages, especially if it's not treated early. Each stage can have different signs and symptoms as the bacteria spread.
Okay, so what's the first stage look like?
That's called stage 1, early localized disease. This usually shows up anywhere from, say, 1 to 30 days after the tick bite. The average is around 7 days.
And what are the signs?
The most characteristic sign, the real hallmark, is the erythema migrans rash, or EM rash. This occurs in about 2/3 of patients.
The bullseye rash.
Well, sometimes. That classic bullseye look is actually more common in Europe. Here in the US, the EM rash is often just a solid, uniformly red or pinkish patch that expands over several days. It's typically round or oval. For official tracking, the CDC defines it as being larger than 5 centimeters across.
And where does it usually appear?
Common spots are places like the armpit, the groin area, behind the knees, also the hairline or scalp, especially on kids. It's pretty rare to see it on the palms of your hands or soles of your feet.
Okay. What else happens in this early stage besides the rash?
Along with the rash, or sometimes even without it, people often get flu-like symptoms. Think fever, chills, just feeling generally unwell, body aches, maybe a headache, and some neck stiffness. Pretty non-specific stuff, unfortunately.
Yeah, that sounds like it could be easily missed or mistaken for just a summer flu. That EM rash seems really important then. But what if you don't get the rash, or maybe you just don't notice it?
That's a huge challenge for diagnosis, absolutely. About 1/3 of people don't get or don't recall the rash. And complicating things further, especially in the southern U.S., there's another tick-borne illness called STARI, Southern Tick-Associated Rash Illness. It's spread by a different tick, the Lone Star tick, Amblyomma americana.
Okay.
And STARI can cause a rash that looks very similar to the Lyme EM rash, but is not caused by Borrelia burgdorferi. So just seeing a rash doesn't automatically mean Lyme, especially depending on where you are.
Right. Context is everything. So if that early localized stage is missed or not treated, what happens next as the bacteria spread?
If it's untreated, the infection can progress to stage 2, early disseminated disease. This usually happens about 3 to 10 weeks after that initial tick bite. Now the bacteria have spread through the bloodstream to other parts of the body.
And what kind of problems does that cause?
You can see a variety of issues. Musculoskeletal problems are common, like intermittent joint pain or swelling, what we call inflammatory arthritis. It might move from joint to joint initially, but often settles into one or maybe a few large joints, especially the knee, ankle, or wrist.
Okay, joint issues. What else?
Neurologic problems are also pretty common in this stage, what's called Lyme neuroborreliosis. One of the most well-known signs is cranial neuropathy, most often affecting the facial nerve. This causes facial palsy or Bell's palsy, where one side of the face droops.
Right, I've heard of that.
And a unique feature of Lyme-related facial palsy is that it can sometimes affect both sides of the face, which is quite unusual for other causes of Bell's palsy.
Interesting. Other neuro issues.
Yes. You can also develop meningitis, which causes symptoms like severe headache, neck stiffness, and sensitivity to light, or even mild encephalopathy, which can manifest as problems with memory, concentration, sort of a brain fog.
Oh, okay. Anything else in stage 2?
Less commonly, the heart can be affected, leading to Lyme carditis. This can cause issues with the heart's electrical conduction system, like heart block or inflammation of the heart muscle itself, myocarditis. Ocular problems like conjunctivitis or blurred vision and eye pain can also occur, but they're rarer.
It really does affect multiple systems. You mentioned European variations earlier.
Yes. There's a specific skin lesion called Borrelia lymphocytoma. It's like a small, bluish-red nodule. It's uncommon overall, but seen almost exclusively in Europe, often on the earlobe in kids or around the nipple in adults. Different strains of Borrelia over there cause slightly different patterns.
So this early disseminated stage sounds pretty serious. What happens if Lyme still isn't caught or treated effectively? What are the long-term consequences?
If the disease progresses untreated, it can enter stage 3, late or chronic Lyme disease. This could occur months or even years after the initial infection. Sometimes there's even a period of latency where symptoms seem to disappear before returning.
And what are the main problems in this late stage?
The primary manifestations tend to be either rheumatologic or neurologic. Chronic arthritis is a major one, again, especially affecting large joints. The knee is involved in something like 90% of late Lyme arthritis cases.
90% in the knee. Wow.
Yeah. And what's complex here is that sometimes, particularly in people with certain genetic markers, the arthritis might persist partly due to an ongoing autoimmune reaction, even after the bacteria themselves have been eliminated by treatment.
So the body keeps attacking the joints.
In some cases, it seems that way, yes. Then there are the late neurologic complications. These can include a subacute encephalopathy with more significant cognitive issues, a chronic progressive inflammation of the brain and spinal cord, or late nerve damage causing pain or numbness. Some of these symptoms can overlap with conditions like fibromyalgia.
And didn't you mention a skin condition mostly in Europe?
That's right. Acrodermatitis, chronica atropicans, or ACA. Again, almost exclusively seen in European patients with certain Borrelia strains. It starts with inflammation, often on the hands or feet, and over time leads to severe thinning and atrophy of the skin. It's sometimes described as looking like cigarette paper skin.
Okay, so given this whole range of symptoms, evolving over time, potentially mimicking other conditions, how do doctors actually diagnose Lyme disease accurately? And then what's the approach to treatment?
Diagnosis can definitely be challenging. It really depends on the stage and the symptoms. Now, if a patient presents with a classic EM rash, lives in or has traveled to an area where Lyme is common, and has likely tick exposure, a doctor might make a clinical diagnosis and start treatment right away without needing blood tests.
Makes sense for the clear-cut cases.
Exactly. But in less clear situations, or for later stages, the CDC recommends a two-tier testing procedure.
Okay, 2 tiers. What does that involve?
Tier 1 is a screening test, usually an antibody test called an EIA, enzyme immunoassay, or sometimes an IFA, immunofluorescence assay. If this first test is positive or comes back equivocal, meaning uncertain,
Then you go to tier 2.
correct. Tier 2 is a more specific antibody test called a Western blot. Now, the timing here is absolutely critical for interpreting the Western blot. If someone has had symptoms for less than 30 days, the lab looks for two types of antibodies, IgM, which usually appear earlier in an infection, and IgG, which develop later.
And if symptoms are longer than 30 days,
Then they typically only look for IgG antibodies. This is because IgM antibodies can sometimes stay elevated for months or even years after the infection is gone, or even be falsely positive due to other reasons. Relying on IgM alone after the first month can lead to misdiagnosis.
so interpreting these tests isn't straightforward.
Not at all. There's also a newer FDA-approved option called a modified two-tier test, which uses two EIAs instead of an EIA followed by a Western blot, and it's considered equally accurate. But the challenges remain. You can get false negatives, especially very early in the infection before the body has mounted a detectable antibody response.
Right, the test might be done too soon.
Precisely. And you can also get false positives, where the test is positive, but the person doesn't actually have Lyme. This can happen because of cross-reactivity with antibodies from other infections like Rocky Mountain spotted fever, syphilis, or even autoimmune conditions like lupus or rheumatoid arthritis.
Wow, so it really sounds like these tests need careful interpretation in the context of the patient's whole picture. It's definitely not just a simple yes or no answer from a lab report.
That's exactly right. You absolutely cannot diagnose Lyme disease based on a blood test alone without considering the clinical context, the symptoms, the exposure risk, the timing. It requires clinical judgment.
So once a diagnosis is made, what's the general approach to treatment?
The good news is that prompt antibiotic treatment is highly effective, especially when started early. Most patients with early-stage Lyme disease recover rapidly and completely. The specific choice of antibiotic, the route, whether it's oral pills or intravenous, IV, and the duration of treatment all depend on the patient's specific symptoms, age, and the stage of the disease.
Can you give us a quick overview of the typical antibiotics used?
Sure, for that early localized rash, the EM rash, or even early disseminated disease without neurological or severe cardiac involvement, common oral antibiotics are doxycycline, amoxicillin, or ciprofloxacin. Treatment duration is usually around 10 to 14 days.
Okay. Are there different choices for kids or pregnant women?
Yes. For children under 8 years old, and for pregnant or breastfeeding women, amoxicillin or ciprofloxacin are generally preferred. Traditionally, doxycycline was avoided in young children due to a risk of permanent tooth discoloration, although some more recent research suggests short courses might be safe. That's a discussion for the doctor and patient.
Right. What about the more serious cases, like the neurological Lyme or the heart involvement?
For neurologic Lyme, treatment often involves either oral doxycycline or IV antibiotics like penicillin, ceftriaxone, or cefotaxime, typically for 14 to 21 days. Therapy is often preferred if there's clear involvement of the brain or spinal cord. For Lyme arthritis, the first step is usually a longer course of oral antibiotics, about 28 days. If that doesn't resolve the arthritis, IV antibiotics might be used.
And the heart issues. Lyme carditis.
For Lyme carditis, treatment involves oral or IV antibiotics for 14 to 21 days. Patients with more severe heart involvement, like significant heart block or symptoms like fainting, definitely require hospitalization for close monitoring and potentially IV treatment.
Okay, that covers the standard treatment. But this brings us to something that's, well, often really complicated and even controversial. What happens when people have symptoms that linger after they've completed that recommended antibiotic course? This seems to be a major point of confusion and frustration.
It absolutely is.
Yeah.
This phenomenon is generally referred to as post-treatment Lyme disease syndrome, or PTLDS.
PTLDS. Okay.
It describes a situation where patients experience persistent symptoms like fatigue, musculoskeletal pain, or cognitive difficulties, that brain fog we mentioned, for months or even years after finishing standard antibiotic therapy for confirmed Lyme disease.
Yeah.
Estimates suggest this might affect somewhere between 10 to 20% of patients.
That's a significant number. So what's the understanding here? Is it ongoing infection?
Well, that's where the controversy really lies.
Yeah.
And it's crucial to understand what the evidence shows. Multiple rigorous placebo-controlled clinical trials have investigated whether additional or prolonged courses of antibiotics help patients with PTLDS.
And what did they find?
They consistently found no convincing evidence that long-term antibiotic therapy provides lasting benefit for these persistent symptoms.
No benefit.
No significant durable benefit compared to placebo. And importantly, extended antibiotic therapy, especially IV antibiotics, is not without risk. It carries significant potential dangers, including serious infections like C. difficile colitis, sepsis from IV lines, gallbladder problems, blood clots, and the CDC has even reported deaths associated with inappropriate long-term antibiotic use for presumed chronic Lyme.
So more antibiotics aren't the answer and can actually be harmful. If it's not an active infection, what is thought to be causing these lingering PTLDS symptoms?
That's the million-dollar question, and research is ongoing. The leading hypotheses suggest it might be related to residual damage from the initial infection or perhaps a maladaptive immune response. The body's immune system might remain activated, or there might be persistence of non-living bacterial components, like fragments of the bacteria's cell wall, that continue to trigger inflammation even after all the live bacteria are gone. It seems to be more about the body's response rather than a persistent active infection needing more antibiotics.
Okay, that's a really important distinction. So managing PTLDS requires different approaches focused on symptoms, not more antibiotics.
Exactly. Symptom management, supportive care, addressing sleep issues, pain management, cognitive rehabilitation, those are the current evidence-based approaches.
All right, let's shift gears slightly. Prevention is always better than cure, as they say. What can we, as individuals, practically do to protect ourselves and our families from getting Lyme disease in the first place?
Great question. Prevention is key. There are several layers of protection. First, avoidance. If you're in an area known to have ticks, try to stay on cleared trails. Avoid walking through dense woods, high grass, or brushy areas if you can.
Okay, stick to the path.
Right. Second, protective clothing. When you are in tick habitats, wear long sleeves and long pants. Tucking your pants into your socks can really help. If you have long hair, tying it back or wearing a hat is a good idea. And light-colored clothing makes it easier to spot ticks that might have crawled onto you.
Makes sense. What about repellents?
Repellents are very important. Use EPA-registered insect repellents containing active ingredients like DAT, picaridin, IR3535, or oil of lemon eucalyptus. For DT, a concentration between 10% and 35% is usually effective. Higher concentrations don't necessarily work better, they just last longer. Maybe 2 hours for 10%, up to 5 hours for 30%.
Any precautions for kids?
Yes, definitely. The American Academy of Pediatrics recommends using products with no more than 30% DT on children and not using DT at all on infants younger than 2 months old. Always follow the product label instructions. Another option is treating your clothing and gear like boots, pants, socks, tents with products containing 0.5% permethrin. Permethrin kills ticks on contact, but it should not be applied directly to the skin.
Okay, permethrin for clothes, DET, or others for skin. Got it. What else?
The final and absolutely crucial step is tick inspection and proper removal. After spending time outdoors in potential tick areas, you need to do a thorough, full-body tick check on yourself, your kids, and your pets. Pay special attention to hidden spots. Under the arms, in and around the ears, inside the belly button, behind the knees, between the legs, around the waist, and especially in the hair and scalp.
Daily checks are best.
Daily checks, yes. Especially during peak season or after known exposure, showering soon after coming indoors can help wash off unattached ticks. It is a good opportunity to do a check.
And if you find a tick that's attached, there are lots of folk remedies out there for removal. What's the right way?
You're right. Ignore the folklore. The best way is to use clean, fine-tipped tweezers or forceps. Grasp the tick as close to the skin surface as possible. You want to grab its mouth parts where they enter the skin.
Right at the skin level.
Exactly. And pull upward with steady, even pressure. Don't twist or jerk the tick. This can cause the mouthparts to break off and remain in the skin. If this happens, try to remove the mouthparts with tweezers. If you can't, leave it alone and let the skin heal.
Okay, steady upward pull. What should you not do?
Definitely do not squeeze or crush the tick's body, as this can force infectious fluids back into you. And absolutely avoid using things like petroleum jelly, nail polish, or heat like a match to try to make the tick detach. These methods are ineffective and can actually increase your risk of infection by agitating the tick and causing it to regurgitate.
Good to know. Just tweezers, steady pull. After removal, clean the bite area and your hands thoroughly.
Precisely, with rubbing alcohol and iodine scrub or soap and water.
Okay. Now, what about that idea of taking an antibiotic just in case after a tick bite? Is that something people should do?
That's called antibiotic prophylaxis. And the general answer is no, it's not routinely recommended after every tick bite.
Why?
Because the actual risk of getting Lyme disease from a single tick bite, even in areas where Lyme is very common, is quite low, estimated at only 1 to 2%. And as we discussed, early treatment, if symptoms do develop, is highly effective. So routinely treating everyone who gets a bite would mean exposing a lot of people to antibiotics unnecessarily.
Right. Overuse of antibiotics is a problem, too.
Exactly. However, there's a very specific situation where a single dose of doxycycline might be offered as prophylaxis. But all of the following criteria must be met.
Okay, what are they?
1. The tick must be identified as an Ixodes scapularis tick, the deer tick. 2. The tick must have been attached for at least 36 hours. This is usually judged by how engorged or swollen the tick looks, or if you know how long it was there.
36 hours minimum.
3. The prophylactic antibiotic dose must be started within 72 hours of removing the tick. 4. The bite must have occurred in a geographic area where Lyme disease is highly endemic, meaning the local rate of ticks infected with Borrelia burgdorferi is known to be 20% or higher.
So a high-risk area.
Yes. And 5. The person must be able to take doxycycline, meaning they're not allergic, not pregnant or breastfeeding, and generally over 8 years old based on current guidelines. If all those conditions are met, a single 200 milligram dose for adults or weight-based dose for children over 8 might be considered. But it's a very specific scenario.
That's much stricter than I realized. What about vaccination? Is there a Lyme vaccine?
There was a vaccine called Limerix, available in the late 90s and early 2000s. It worked by targeting a protein called OspA on the surface of the bacteria while they were still inside the tick. However, due to several factors, including reports of side effects, though later reviews didn't find strong evidence of major issues, and ultimately poor public demand, it was voluntarily withdrawn from the market.
So no vaccine currently.
Not currently available for humans, no. But there's definitely ongoing research. One promising candidate in late-stage trials is called VLA14, which is a multivalent vaccine targeting different OspA types from various Borrelia species found in the U.S. and Europe. There's also exciting research into novel approaches, like mRNA vaccines, similar to some COVID vaccines, but designed to target proteins in tick saliva. The idea there is to make your body react quickly to the bite itself, potentially alerting you sooner or even preventing the tick from feeding long enough to transmit pathogens.
Fascinating. Maybe something on the horizon then. So connecting all this back to the bigger picture, where exactly is Lyme disease most common today and who tends to be most affected?
Okay, geographically in the United States, Lyme disease incidence is highest in the Northeast, like Maine, Vermont, New Hampshire, Massachusetts, Connecticut, New York, Pennsylvania, New Jersey, the Mid-Atlantic, Delaware, Maryland, Virginia, and the upper Midwest, especially Wisconsin and Minnesota.
Those are the hot spots.
Those are definitely the main endemic regions. However, it's important to note that cases have been reported from nearly every state. Increased travel and environmental changes mean you can encounter infected ticks in places previously thought to be low risk. Internationally, Lyme disease, or Lyme borreliosis as it's often called outside the U.S., is also endemic across much of Europe and parts of Asia. The specific Borrelia species can differ in Europe. B. afzelii and B. garinii are more common there, and they sometimes cause different patterns of disease, like more skin manifestations like ACA or more neurological involvement, respectively.
And what about demographics? Who gets Lyme most often?
It's reported more frequently in white individuals. This might reflect differences in exposure patterns, but also potentially diagnostic challenges, as the classic EM rash can be harder to recognize on darker skin tones, possibly leading to underdiagnosis. Age-wise, there's a clear bimodal distribution, meaning 2 peaks.
2 main age groups.
Yes. The first peak is in children aged 5 to 14 years, and the second peak is in adults aged 45 to 54 years.
Why those groups?
It's thought to correlate with periods of higher outdoor recreational activity. kids playing outside, and adults engaging in gardening, hiking, yard work, etc. in those middle-age years. Overall, there isn't a significant difference in reported cases between males and females.
Well, we have certainly taken a deep dive into Lyme disease today. We've gone through the tiny ticks, the complex stages of the illness, the often tricky diagnosis and treatment, and those really crucial prevention steps. It's definitely clear this is much more than just a simple tick bite. It's a really multifaceted health challenge.
It really is, and I think one of the key takeaways is that while we have quite effective antibiotic treatments for the acute infection itself, the persistence of symptoms in some people, that PPLDS picture, really underscores how much we still need to learn about the complex, lingering interactions between the Borrelia bacteria, or maybe its remnants, and the human immune system long after the active infection is cleared. Understanding that ongoing inflammatory process is a major frontier in Lyme research.
That raises a fascinating point for you, our listener, to think about. Given how far medical science has come, what do you think might be the next big breakthrough? What could truly help us understand and manage not just the initial Lyme infection, but also those more enigmatic, persistent effects that some people experience long after the tick bite is gone? Something to ponder.
This audio is for informational purposes only and should not be considered medical advice. Please consult a qualified healthcare professional for personalized guidance.